What is NIV? Non-invasive ventilation uses a mask on the face to deliver set flows of air under pressure to the spontaneously breathing patient. The term NIV covers both BiPAP and CPAP. What is BiPAP? Bi-level positive airway pressure. This provides two set levels of positive pressure. One higher inspiratory positive airway pressure, referred to as IPAP, and one lower expiratory positive airway pressure, referred to as EPAP. BiPAP increases tidal volumes, decreases the work of breathing, and rests respiratory muscles. The aim of BiPAP is to improve hypercapnia, acidosis, and oxygenation, i.e., to improve type 2 respiratory failure. What is CPAP? Continuous positive airway pressure. This is pressure at one level delivered continuously throughout the breathing cycle. CPAP prevents airway collapse at end of expiration, thus splinting airways open. CPAP also increases functional residual capacity. The aim of CPAP is to improve oxygenation, i.e., to improve type 1 respiratory failure. These patients are often severely hypoxic and require urgent review by the critical care team. CPAP will not be covered further in this training video. Acute hypercapnic respiratory failure is when a patient presents with a PaO2 of less than 8 kilopascals and a PaCO2 of more than 6 kilopascals that is associated with a respiratory acidemia, i.e., a pH less than 7.35. This may also be referred to as a type 2 respiratory failure. NIV is the first line treatment of acute hypercapnic or type 2 respiratory failure that persists despite optimum medical management. More and more NIV is being used for the treatment of acute hypercapnic respiratory failure caused by an increasingly wide variety of conditions, including obesity, hypoventilation syndrome, and neuromuscular conditions. Prior to commencing NIV, the bed manager needs to be notified to source a bed on fearing ward or within critical care, as stated in the decision-making tool for acute NIV in MEHT. This can be found on the intranet. If there is no capacity on fearing ward due to availability of a machine, beds or staff, then refer to the escalation planning document, which is also located on the intranet. The patient may need referring to the ICU consultant on call to be considered for transfer to critical care with a ceiling of care in place. Prior to commencing NIV, explain the process to the patient, carers, and any family that are present, then gain consent. You can also provide them with an NIV patient information leaflet, the NIV prescription form, and a treatment escalation plan needs to be completed by the medical team. All of these documents can be found on fearing ward alongside the NIV machines and in A&E resus. Wherever possible, position your patient in a high sitting position. To start BiPAP, firstly obtain a V60 machine, mask and circuit from fearing ward or ICU, depending on your patient's destination. Ensure the machine is fully charged by checking the orange light is showing solid on the front of the machine. Check the mask does not have a blue elbow, as these masks are not compatible with the V60 machines. At Broomfield Hospital, There are two types of mask available: a full face mask or oronasal mask. Both come in different sizes, so it is important to measure your patient before opening a mask. To measure for an oronasal mask, hold the sizing guide found on the bottom of the mask bag up to the patient's nose and mouth. Check the top edge rests on the bridge of the nose with none of the eye area appearing in the cutout. The bottom edge should rest below the bottom lip and above the chin. To start BiPAP, first plug the machine into the electrical supply and switch on. Connect the oxygen supply via the Schrader valve, removing the flow meter if necessary. Then attach the circuit. The large bore tubing delivers the flow and the small bore tubing senses the pressures. Ensure the exhalation ports are free on the tubing and the mask at all times, as this prevents rebreathing of CO2. Switch on the machine via the power button. It will now alarm and do a self-test. Select the exhalation port required by going to the menu. Select the mask port button, then select the number that corresponds with the number on the elbow of the mask being used. Press accept. When asked about DEP, disposable exhalation port, press accept. Select spontaneous timed mode via the tab on the bottom of the screen. This will display as a blue screen when active. Select IPAP and use the arrows to set at 10, then press accept. Select EPAP and use the arrows to set at 4. This will provide a pressure support of 6. Again press accept. Please note that the machine will always start on the last settings used, so it is important to check each setting. Set the rate to 10. This ensures a minimum respiratory rate of 10 if the patient's own rate falls below this. Set the inspiratory time to 2.0 seconds. Set the prescribed oxygen percentage. Ensure the ramp is off for the initial setup. Set the rise time to 3. This adjusts the speed of the breath delivered for comfort. It ranges from 1 to 5 on the V60 machine. A patient with a fast respiratory rate may find a setting of 1 or more comfortable, while a patient with a slow respiratory rate may prefer a setting of 5. You can silence the alarm using the alarm silence button at any point after the initial self-test, and you can use the alarm reset button to clear previous alarm displays. Having already sized and obtained the appropriate mask for your patient, attach to the circuit and introduce to your patient's face with continual explanation and reassurance. If using an oronasal mask, consider applying a protective strip of hydrocolloid dressing to the bridge of the nose. Position the bottom edge of the mask onto the patient's chin first, then roll up and onto their face, lifting the lower straps up and over the back of their head. Stop, reassure and gently encourage if the patient becomes distressed or agitated. Stop if the patient withdraws consent. Holding the mask onto the patient's face, pull the lower straps down the back of their head and around either side of their neck. This is easier with 2 people to assist. Bring the lower straps to the front of the patient's face and clip into the mask. Tighten the lower straps simultaneously using the Velcro fastenings. Tighten the upper straps in the same way. Then adjust the strap that lies across the top of the head. All straps should be firm enough so there is no obvious large leak of air or loud noise on inspiration, yet loose enough for a finger to pass under. Check the leak value on the machine. This should be between 10 and 60. If using an oronasal mask, you can then release the clip at the top of the mask to relieve pressure on the bridge of the nose. Once your patient has the mask fitted and is comfortable, increase the IPAP setting by 2 every 5 to 10 minutes to a maximum of 20 over the next 20 to 30 minutes. It is important to monitor patient comfort and compliance and stop any increases if not tolerated. If target saturations are not being achieved, then the EPAP can be increased accordingly to a maximum of 8. When increasing EPAP, you must also increase the IPAP by the same amount to maintain the pressure support value. If target saturations are still not met, despite increasing the EPAP, then the oxygen percentage can be increased up to the prescribed level. If IPAP needs to be increased beyond 20 or EPAP beyond 8, then discuss this with the senior respiratory team. An arterial blood gas should be taken 1 hour after NIV is started to assess the patient's response and guide any further adjustment of settings. Try not to make any adjustments in the 20 to 30 minutes prior to taking an arterial blood gas, as these changes will not be reflected in the blood gas results. The ramp time is the time the machine will take to increase IPAP and EPAP to a set pressure from a lower one. It is a comfort setting which is useful once NIV treatment is established and the patient is returning to the mask after having a break off for a nebulizer, drink and/or food. The ramp setting allows the machine to start at a lower pressure and then gradually increase to the previously set pressure over a period of time which you can set, the minimum being 5 minutes up to a maximum of 45 minutes. This setting is not required in the initial setup of NIV. Using the standby mode will prevent any unnecessary alarms when you remove the mask from the patient's face for a break. While the mask is on the patient's face, press the standby tab at the bottom of the screen. Remove the mask from the patient's face. The flow will automatically stop. The flow will automatically start again when the mask is replaced back onto the patient's face. Over the first hour, titrate IPAP to achieve a tidal volume of 10 ml per kilogram ideal body weight. A tidal volume of 8 ml per kilogram may be acceptable if the patient shows signs of intolerance. The highest advisable IPAP is 30 centimetres of water. In cases where the patient is showing an inadequate response and the patient is for escalation to critical care, escalation should occur within 4 hours of initiation of NIV or within 1 hour of treatment at effective pressures, whichever is the sooner. Adequate response is defined as a reduction in PCO2 of at least 1 kilopascal, with a PO2 consistent with oxygenation in target oxygenation saturations range. Following any significant change in settings, the patient should be reviewed clinically with a repeat blood gas at 30 to 60 minutes following the change. With every breath, the display will show a coloured bar for either spontaneous breaths for patient effort in blue or timed breaths delivered by the V60 in orange. If only timed breaths are being delivered, seek senior input. To turn the V60 machine off, press the power button on the bottom left-hand corner of the front of the machine. Then confirm by pressing ventilator shutdown on the screen when prompted to do so. All patients must be reviewed clinically with a repeat ABG at 1 hour from initiation of acute NIV. All patients must be reviewed clinically with a repeat ABG after 4 hours of acute NIV treatment. All patients must be reviewed in person by a consultant within 14 hours of admission. All patients receiving NIV should have a daily specialist review. Arterial blood gases need performing once daily once clinical stability is achieved. Document if ABGs are taken on or off NIV and on what oxygen. Oxygen prescription needs to be completed for on and off NIV. Patient observations should be recorded every 15 minutes for the first hour and then hourly thereafter. Fill out the NIV documentation, NIV communication and progress page, OBS charts, care plan, and of course input the observations also on Vital Pack. While taking observations, note the patient's synchronicity with the ventilator, their chest wall movement, any use of accessory muscles, and their respiratory rate. Check the facial area around the mask for any soreness and treat accordingly. A leak of up to 60 litres is acceptable. The mask can be cleaned daily with warm soapy water. Be sure to optimise ventilation by maintaining a good high sitting position whenever possible. NIV should be delivered continuously until the respiratory acidemia has resolved. Offer frequent mouth care and encourage the patient to drink and eat once clinical stability has been achieved. Until respiratory acidemia has resolved, breaks should be short, kept to 10 minutes and under. Ensure correct oxygen prescription is applied when off NIV. Patient comfort can be the key to success. Offer reassurance to the patient and relatives. Always ensure call bell is within reach. If the arterial blood gases show static or worsening hypercapnia and acidemia, try optimising the patient's position. Also check the mask fit and any leak. Check patency of exhalation ports and check the circuit for leaks. Ensure that the appropriate oxygen is being delivered to achieve target SATs. Ask for a doctor to review the treatment of underlying conditions and optimise. Check patient compliance and ensure continuous use of NIV. Consider increasing IPAP to a ceiling of 30 centimetres of water and discuss this with the medical team first. Consider decreasing the EPAP if this is set high. If the oxygenation target is not being achieved, try optimising the patient's position. Check mask fit and leak. Increase EPAP, but remember to also increase IPAP by the same amount to maintain pressure support value. Check the oxygen tubing is attached and the level is set correctly. Ask for a doctor to review treatment of underlying conditions and optimise. Increase the oxygen being delivered up to the prescribed level. If the mask is leaking, remember that leaks are normal and acceptable up to 60 litres, but larger leaks may cause inefficient ventilation, excessive noise, a dry mouth and nasal symptoms. Do not be tempted to over-tighten the mask. You should always be able to get a finger underneath the mask. Check your patient's position and consider an alternative mask. If there is asynchrony between the patient and the ventilator, or poor patient compliance, ensure the tidal volume is not excessively high, and if so, then consider reducing the IPAP. Check the rate is not excessively high. Consider an alternative mask. Consider adjusting the rise time, 1 for higher respiratory rates and 5 for slower respiratory rates. Consider using the ramp feature. Consider one-to-one nursing, offer more support and reassurance to the patient, or involve family members and/or carers. Consider sedation. However, the patient will need to be nursed in the critical care environment for close monitoring purposes. If an adequate tidal volume is not being delivered, you could try increasing the IPAP to a ceiling of 30 centimetres of water with senior involvement. Consider bronchospasm, mucus plugging, pneumothorax or atelectasis as a cause and treat accordingly. Ask a doctor to review the underlying pathology and optimise treatment. Check equipment and unkink or replace any tubing if necessary. If you are concerned that a pressure sore may be developing, regularly check the area around the mask for any marking, redness or soreness. Pay particular attention to the area around the ears, head and bridge of the nose. Consider using a hydrocolloid dressing or gauze pads to protect vulnerable skin. If the patient reports a dry mouth, ensure regular mouth care is being carried out. Encourage the patient to eat and drink, yet try to keep breaks to a minimum in the first 24 hours or until the respiratory acidosis has resolved by clustering care. If gastric distension is noted or reported, consider a nasogastric tube, accepting that this may increase the leak of the mask slightly. Check when the patient last had their bowels open and treat any constipation appropriately. Reduce the IPAP if possible. NIV training should be completed yearly along with the competency. Please note that V60 machines have a 2-hour battery backup time for transfers, but should be plugged into the mains whenever possible. A second oxygen cylinder may be needed for patients on a high oxygen percentage for transfer. When possible, discuss with the patient if they would consider NIV treatment in the future if required, and document this in the medical notes and on Lorenzo. Encourage the medical team to document details of acute NIV treatment, including the last arterial blood gases, in the discharge letter, also stating if the patient will be a suitable candidate for future NIV treatment. Now complete the medical equipment competency, CS 151 00313 for V60 machine. Read guidelines found on the intranet, 10061 non-invasive ventilation and CPAP in adults. Attend a practical face-to-face training session. Contact NIV practitioner on bleep 907623 958 360 to arrange this. All the information and documents covered by this presentation can be found on the intranet.